yes, history being a very important subject, and the history of Caesarean section, and thank you for the invitation to take part in this fascinating conference. So much more than just a history of an operation or a history of medicine and improving care. It's also a history of religion, cultures, and society, but especially of women and mothers. And I'd like to commend this book to you. It's written by Tom Baskett, one of the great scholars and writers in obstetrics, and which provides a lot of information. I don't know whether any of you have read it, but it's a very detailed description of what happened over the years. Now, there's been a number of influencing factors historically, and these are most of them here. The name, to start off with, has been under much discussion, down to Julius Caesar being delivered by Caesarean section, but that probably isn't true. But what is true is, and we've got to remember that Caesarean section was initially a post-mortem procedure, and it was a law of the royals, or after that the Caesars in Rome, that whenever a mother dies, then the baby is removed. I think initially people were worried that, you know, the baby might still be alive. And we know, though, now that post-mortem Caesarean sections sadly don't do very well. And that's how the name Caesarean became part of lexicon of Caesarean section. But it's interesting to go to the Scandinavian countries and Germany, where the name is Kaiserschnitt or Kaiserschnitt. And I think it was an operation or an event of such great undertaking that it deserved a very important name. Religion and culture, likewise, for salvation and baptism, often babies were delivered, hopefully with some sense of life, so that they could be appropriately baptized. And law and inheritance too. It was an understanding in some European countries that the inheritance went different ways. If baby was born alive and then died, it became down to the husband, as opposed to if the baby was dead beforehand, then it passed to the wife's family. Obviously, that isn't true now. Professional opinion and medical politics, never far away from Caesarean section. Maternal opinion, very important, and over the years has become more important, and rightly so. Perinatal order, evidence-based medicine, we'll talk a bit about like that. But also the economics is becoming an issue nowadays, and I won't be able to have time to go into that. But I think some of the ways that that's calculated is clearly flawed and should be thought of again. Caesarean section, if you want to call it that, or an incision in the abdomen, has probably been performed inadvertently by traumatic accident for many millennia. And I think in the book, and I think it's already been referred to, there are a lot of things that have been described, but they really, not all of them probably have been validated or verified. And this is just a story of an angry bull which ripped open the belly of a farmer's wife. The child survived, but the farmer and his wife both died 4 hours later. Self-performed Caesarean sections, that did happen. Again, some of the descriptions vary, and again, whether they're validated, but it definitely did happen. The ultimate form of maternal request, if you think about it. Layman, and this case has already been referred to. What was interesting about this case, not only was that it reported 86 years later, after a prolonged labor in the first child, but also that delivered 5 more babies, supposedly VBACs. And the description included delivery of a baby with no mention or little mention of bleeding. So it could actually have been an advanced extrauterine pregnancy, or maybe did not take place. It was reported by a medical student some 80 years after it happened. Cases performed by medical persons certainly did happen in the 15th and most of the 16th century, and there was a sometimes post-mortem, but you know, now we're beginning to talk about Caesarean sections, if not to save the mother, certainly to save the baby. And there was always a discussion about that, and likewise today, where we have got 2 patients as a balance between the 2. But the first witness and documented Caesarean section by a physician was performed in Germany in 1610. The mother died, but the baby survived. And this is just roughly when the first cesarean sections, but I'm sure if you go and pursue the literature to the detail, some are verified and some aren't. But it was around that time. The prevailing medical wisdom was strongly against cesarean, with its almost inevitable fatal outcome for the mother. And the reason for this, really, in this era, was that cesareans were only performed after a prolonged labor on women who were dehydrated, exhausted, and infected, and most of the time with an atonic uterus. And in addition to that, the initial cesarean sections, while the abdomen was sutured, the uterus was not sutured, and this just exacerbated the morbidity and the bleeding and the morbidity. And it wasn't until 1769 that Jean Lebas first advocated suturing the uterus. But like a lot of these things, it took another 100 or 200 years before it was taken up seriously. And I think we can think of examples today in all branches of medicine where that still happens. In the 15th and 16th century, the first medical text advocating cesarean, before the mother was an extremist, was published by the French physician Francois Rousseau. Now, he was a physician, and physicians at that time were educated, university education, but they weren't surgeons. They didn't operate, barber surgeons, as they were called, and there was this big divide. So here you have a textbook about cesarean, advice given when to perform it, but he actually probably never carried out the operation himself. It was then that audits started occurring, and Robert Harris was the first one. And these are some interesting figures, and it just shows how simple incidents of things can lead to asking questions. And I think something that we should be aware of today. The types of cesarean sections, self-performed, cattle horn, and physician-performed, immediately you can see the maternal mortality is much better if you do it yourself rather than physician. And this incidence is so striking. The numbers are small, obviously, but the numbers of cesareans were small. But it was because of waiting and not making a decision, and waiting so long that they walked away in the end rather than doing a cesarean section. I mean, the extreme, can you imagine it in prolonged labor for whatever reason? And the dangers of doing a cesarean section was so high by the time 12 different opinions had been got and decided to do it, that the mother would have died, and the surgeon or the doctor didn't want to be involved with a death after a cesarean, which was a real problem at that stage. But it became more and more obvious that if you do a cesarean section early rather than late, the maternal mortality and perinatal mortality is much better when you do it early, which prolonged labor comes back to the whole issue of prolonged labor. Porro, Pavia, in the 19th century, there were real problems with cesareans. They were being done a little bit more often, but they did very poorly. And one of the ways that they were looking to try and improve that, continually trying to improve, was to do a subtotal hysterectomy at the same time. Very good surgical principle, cut it off of the cervix and bring out the cervical stump to the abdomen and make sure that it's drained. And this made a huge difference, even though it was a much bigger operation, and the maternal mortality rate was half. Very scientific and based it all on experiments and very scientifically proven, but obviously a big operation. All kinds of other modifications, including extraperitoneal approach, and it's hard to imagine how they tried to do that and at that time, but it was because of the problems of peritonitis, infection, and bleeding. Semmelweis then, in the mid-19th century, recommended hand washing, silver wire sutures from the US to repair the uterus, intravenous fluids, antisepsis, and anesthesia beginning to take place in 1846. But the problem was, and around that time, there was a great incidence of contracted pelvis. And some of us still live in the era, probably not today, when you even discussed pelvimetry. It's not that long ago. And you can actually think now we would never think of it, but in those days it was completely different, and they had to do measurements to try and find out measurements, digital obviously at that time rather than x-ray, because the real choice was only cesarean section versus a difficult vaginal operative delivery, symphysiotomy with all the sequelae of that, and craniotomy or embryotomy. And it wasn't easy, certainly not sadly easy for the baby, but it wasn't easy for the mother either. Both had significant mortality rates. Just to change the slight emphasis here is this is something that remains even today. And it's a quote from Thomas Radford: "To my knowledge, there had been no subject connected with medicine which has created more bitterness of feeling and animosity in the minds of those who may be classed as Caesareanists and anti-Caesareanists." And again, pointing out what the problem was, and never mind whether to do one or not, even the way you did it became an issue. But the real process, the real advances came in the late 19th century, when two obstetricians, Carer and Sanger, independently suggested meticulously closing the uterine wound. There were other differences in the techniques. Carer placed the uterine incision lower and transverse, Sanger high and longitudinal. So one is very much easier. You open the abdomen, longitudinal incision, baby comes out very quickly, suture it, and very specific with Lembart sutures, focusing, burying the uterine wall, and the Carer incision, which was very much lower in the pelvis. But it was Sanger's classical Caesarean section that held sway, while Carer's transverse lower segment technique was forgotten. And the politics and who knows who, how the information is distributed, you wonder what different social media would have made to the different ways of doing things then. But one of the issues, and during the wars and the First World War, and certainly some of the wars, communication wasn't as great as it could be. And there was this big difference between what's happening in Great Britain and Ireland and Europe as a separate phenomena, and also the US. But this then, Murdoch Cameron, who worked in Glasgow at the end of the 19th century, started to do a series of pre-labor elective Caesarean sections on rachitic small-statured women. These were children that had grown up with rickets or otherwise osteomalacia as the adult disease. And publication of this series was a real milestone. And it was a brave decision to actually bring the timing of the Caesarean section to either before labor or just after labor had started. These mothers, these poor mothers, were no way going to deliver vaginally. And can you imagine having a baby and a pelvis like that? It is almost a death sentence, if you like, because it's not going to be able to come out. The maternal mortality rate was reduced to 5 to 10% at the end of the 19th century. And you can see how, again, people started repeating and showing that no labor, labor with ruptured membranes, labor with frequent pelvic examination, again, showing that prolonged labor serves no or little benefit to either mother or baby. But Monroe Kerr then was responsible for the change from the classical longitudinal incision in the uterus to the low transverse incision, Carer's technique. 1930s, mortality rates came down to 1 to 1.5%, and this is where the switch occurred, began to occur between the classical and the low transverse. Good surgical principle, really, and I'll come back to this later. You do the incision as low as possible, you cover it up peritoneum, maybe a bit of omentum, and it will, in the short term, heal much better. So this idea was that you do it in the lower segment and you do it as low as possible, very clearly described just above the cervix. And then Michael Stark recently, in the last 20, 30 years, refined the technique. But then all of these other things made a big difference. Oxytocin drugs, antibiotics, improved suture material, modern anesthesia, blood transfusion, regional anesthesia, and other benefits. But then during the 1980s, the Caesarean section gradually increased over the beginning of the 20th century. But in the 1980s, a number of significant events took place. And the first publication was this publication by Bottoms and Sokol in the New England Journal. And they spotted it straight away. This is just when Caesarean sections were beginning to increase, that the management of obstetric problems of previous Caesarean birth and dystocia would have to be addressed in order to alter the increase in operative delivery rates. They were far ahead of their time. And at that stage, the Caesarean section rate wasn't very high. Well, what is high, 5 to 8%, at the most, probably lower. And our suggestions for safely limiting Caesarean birth rates do not represent new ideas. They certainly aren't, and even today they're not new ideas, but they have not received appropriate emphasis in the recent literature or in residency training programs. And what this showed was they showed that the Caesarean section rate was going up and the maternal mortality rate was going down. And they wondered whether the two were connected, and likewise with the perinatal mortality. And then this brings us forward to Ireland, the National Maternity Hospital. Now, Driscoll was quick to publish a paper showing that while both in the US and in the NMH, the perinatal mortality rate was going down, the Caesarean section was going up in the US, but the Caesarean section rate in the NMH, National Maternity Hospital, remained the same. And he went on to publish that to point out the problem in the US of the problem of dystocia, and that it was managed differently. And this started all the debate about the Caesarean section. Indeed, it started such a debate that there were these three, if you like, articles debating backwards and forwards between Ken Levino, a very eloquent writer with many references to the House of Horn and Ulysses, and O'Driscoll. And if anybody wants to read anything to explain the nuances about comparing Caesarean section rates or perinatal mortality rates, you need to read these. They're so beautifully written. You read them again and again, and you pick something up each time. But that brought out the problem, and a lot of the ideas from these three papers made up the ideas for the 10 groups. And 1987, at the same time, all of this happening at the same time, there was this paper from London, Philip Steer from St. Mary's, which did a very small study with, I think, 60 women who were assigned at random. And the argument about, if you like, passive management of labor as opposed to active management of labor. But more importantly to me, it brought up the conflict, the contrasting basis of evidence-based medicine, good and long and big organized databases, as opposed to randomized controlled trials, especially in a subject like labor and delivery, where there's so many nuances to it. The other thing that happened in the 80s was the WHO, who came out with this 10 to 15% Caesarean section rate. And I quote here, it says, countries with some of the lowest perinatal mortality rates in the world have Caesareans of less than 10%. There's no justification for any region to have a rate higher than 10 to 15%. There was no evidence for this at all. They just plucked it out and they referred to the Nordic countries. And ever since then, the WHO have tried to study this and see whether they could actually prove it. And I point to the word neonatal mortality, as is this study from the US. So what has been said about the 10 to 15 and the US study, 15 to 20%, is not perinatal mortality rate, although often it's kind of either confused or used inappropriately. It's neonatal mortality rate. So what it's saying is that if the baby's alive during labor or before delivery, there is no benefit to a Caesarean section rate higher than that. But it ignores completely stillbirth. We induce, rightly or wrongly, we do pre-labor sections to reduce stillbirth. And why should it be the same in every country? I just can't understand that. So again, another figure here, and this is far more recent, saying that the Caesarean section rate should be 15 to 20%. But even in that article, neonatal mortality rate is used as well as perinatal mortality rate. It doesn't affect stillbirth. And the reason why they didn't include perinatal mortality rate was because they don't have the data. The only way to prevent a stillbirth is to either induce or do a pre-labor section. Both, as far as I understand, will increase the Caesarean section rate. And we're really missing the point. Overall Caesarean section rates on their own have long been considered as a mark of quality care. There's so many things that are hangovers from the past about Caesarean section. But it's not the Caesarean section rate or the Caesarean section itself that's the issue, but it's the sequela of doing a section or not doing a Caesarean section and the fetal and maternal outcomes. And we have to really understand that to address this issue, which is our professional responsibility, because not all Caesarean sections are the same. There's all kinds of difference, different pathway to deliveries, different timings, different indications, first stage, second stage, and I'm sure you can agree with that. You know, you can't compare like with like all the time. The biggest criticism we will face in the future is not that the Caesarean section rate pardon me, was allowed to increase, but that we made no effort to study or its implications more scientifically. So in 1998, when I first came to the National Maternity Hospital, all of this was going on. And the real debate that I was interested in was the section rate in spontaneous nullips. And therefore, that became group one, if you like. But to actually analyze big data sets, you might have to make sure that all the other ones that you don't study, you can validate to make sure that they're not being moved to make the group that you're studying more advantageous. And the background to the 10-group classification, so misunderstood, was that you needed a perinatal classification to provide a more comprehensive understanding of cesarean delivery rates within the context of overall clinical practice and perinatal outcomes, so that all perinatal events and outcomes can be classified within the same classification system, and no perinatal event or outcome. I mean, surely we've learned that from history, if nothing else, including especially a cesarean section rate, should ever be considered in isolation from other events and organizational issues. But the 10-group classification has become popularized as a way of analyzing which group were delivered by cesarean, but less attention has been given to using it to analyze the wider perinatal outcome for which it was originally designed. And it's so amazing that when you just start categorizing information, but particularly into these 10 groups, it allows us to confirm known knowns, and I mean confirm what we think we know, identify known unknowns, and actually discover unknown unknowns to improve the quality of care to the mother. So the future, I think, is about understanding a cesarean section rate. You need the 10 groups, you need the indications, you need case mix, perinatal events, and then you need a list of all your processes and guidelines. So you turn it upside down and you actually standardize the way you look at your results, and then compare different processes, something that businesses and professional sports organizations do all the time. And this is just to show the 10 groups. It's very clear which groups contribute to the cesarean section. As many people know, it's group 1 and 2, single cephalic nullips, and you end up with a cesarean there, you're more likely to end up with a cesarean section, a repeat cesarean section. All these other groups are irrelevant, or should be irrelevant. Main reasons: dystocia groups 1 and 2A, which will lead directly or indirectly to an increase in the overall cesarean section rate. Group 5, maternal request. Group 5 mainly, possibly group 4 if they've had a bad experience or a bad outcome before, but also increasingly 2B, and that's pre-labor cesareans in nullips, that term, which is increased. So we need some kind of indications. We haven't got a standard classification for a very common operation with huge significance to society at large, but especially to mothers and babies. And I think we've got to separate pre-labor to spontaneous and induced labor. Just taking our own figures, our problem, even though we've got a very high induction rate, 2/3 of our sections are pre-labor. Making changes in labor is not necessarily, certainly directly going to make a difference. And the contribution from spontaneous labor is 2.6%. Pre-labor, there's also a confusion between the reason for ending the pregnancy and the reason for decision to deliver by cesarean. So that unfortunately doesn't allow us to get all the information out. And I think that should be split up. So you have the reason why you're ending the pregnancy, as we do with inductions, rightly or wrongly, fetal, maternal request at a high level. And then the pre-labor cesarean section, the reason for delivery by cesarean section, recorded separately, and then maybe for medical reasons in mothers who either have no previous section or a previous cesarean section or maternal request. But remember, if you collect the first bit of information and you use the 10 groups, then all that information will be there. The intrapartum cesarean delivery classification, and we hope to publish on the pre-labor cesarean section indications shortly, but the intrapartum one has been published. And very simply, I know I'm running out of time, it's just to try and use a system which simplifies everything. And in labor, or after you've induced somebody, the reason for a section is either fetal, no definition, in the eye of the beholder, but importantly, no oxytocin. Everything else is one or other form of dystocia. It's divided up into slow progress by arbitrarily a cutoff of 1 centimeter an hour. It's got from the beginning to when delivery took place. It's got nothing to do with management or inefficient uterine action, and efficient uterine action, which is either here persistent malposition or CPD. But here you've got 4 groups which one of them will go into. So either poor response, you've treated it according to your guidelines, maximum dose, baby's fine, mother's fine, but you've had to give up. And these two here, either you've treated it with oxytocin, but you're unable to get it to the maximum dose because of either overcontracting or fetal intolerance. And the last one is when you would probably use oxytocin, but within a previous section, you may, for clinical reasons, not use it. And you can actually see here, if you look at all the blues, and this is group 1 and 2A, they're the ones with fetal no oxytocin. All the rest is some form of dystocia. Either you weren't able to treat it for whatever reason, overcontract. It also shows the irrelevance of cesarean sections in group 3 and 4 multips, which are very, very low. Previous scars, a different one altogether. Finally, the maternal request cesarean section, we have to make a definition that will work. And work not only today, but work into the future, because what could be maternal request today may not be maternal request in a few years' time for different reasons. And you can read the definition that we use, or I would encourage. This is the most important thing, though. Women will always, and I really do believe this, would always choose the type of delivery that seems safest for them and their babies. And if a woman chooses a type of delivery that we disagree with, then they might be right and we may be wrong. The care that is being provided is not what we think it is, or appropriate information is not available. And the very last few slides, placenta accreta, an untouched subject to a certain extent until the last 10, 20 years when it's grown in amount. And the first thing we must do is record it. Every country should be able to know the number of accretas they have. There is a problem with the definition, I accept that, but a working pragmatic definition. And we need to, like every other countries, collect that. But more interestingly, and with my good friend Jose Palacios Racamada, when he showed me this, I began thinking, there is a watershed of blood supply, a lack of blood supply in the lower segment, okay? These are end arteries, and you can read what he says here. Receives blood supply from a cervical vagina, which is terminal with only 9 to 12% anastomosis. Therefore, if the pedicle is damaged, healing is compromised because procollagen does not mature into collagen. Improper healing can result in spontaneous reopening, creating a large niche, which is the main predisposing factor for PAS. My hypothesis is that we have gone lower and lower and lower. Many clinicians are worried about getting the baby out. And when Monroe Kerr was suggesting we go lower, it made sense. It was surgically, that was the problem. It was infection, so you pushed it down, delivered it. I'm not sure whether going as low as we do, especially after long labors, will end up with the best healing scar. And this may be reason why the accreta is either increasing or decreasing, or higher in some places and low in others. So I think that it would be interesting to know the accretas that you've got and go back into the index pregnancies before to see whether the first one or the most recent one was done in labor, far on in labor, than or as opposed to preterm labor. And it may be just a phenomena that we've just got to think about these things to make sure that we keep on making sure that we're doing the best thing, because things may change. And this is just showing a specimen where the first cesarean section was done very, very low, had another elective cesarean section, but you can see obviously the accreta happening. So it may not be 6, 7 cesarean sections, it may be where the first cesarean section was done. And if you were going to have an accreta, where would you rather have it? Low down or high up? So I think we have to continually improve things. And it's not always about reducing the section rate, and I know the debate today, but it's also to make sections safer. Cesarean section has always been and always will be a risk-benefit ratio. In medicine, the principles always remain the same, but everything else continually changes, and we never should expect to stand still. We need to be aware of this and always continue to adapt. Thank you.